Hey, 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 welcome back to another edition of Back in Motion Health Talk. We are here with Dr. Silas Jennings again. How you been?
Doing pretty good.
Yeah, life treating you well?
It's been okay. Can't
Okay.
complain.
Nothing exciting going on?
Not too much. Not
No,
too much.
just work,
Just work.
getting people well,
That's right. That's what
helping
we
them
do.
out, helping them out with chiropractic.
That's right.
Well, today we got together and we're just kind of kicking around the clinical football, I guess, talking, and we got to talking about some things. So we just decided to get on here and talk about a few things. So we started off a pretty interesting discussion about radicular pain. Uh, Tell me what your thoughts were on that. What we were talking about was,
Well, radicular pain is something that we see a lot in a chiropractic office, right? But it can manifest from a lot of different things, though, right? It usually presents as numbness, tingling, loss of sensation in an extremity or along a specific nerve root. But you know,
weakness.
weakness, yeah,
Yeah.
and some, if it's gone untreated for quite some time, you definitely get some muscle weakness and neurological deficit.
Yeah. The interesting thing about treating a lot of people that I run into, they think if they have that kind of pain, they should be seeking a surgical intervention or something pretty drastic.
Mhm.
What are your thoughts on when it's appropriate for us to treat them as a chiropractor, and when we should escalate to a more, I guess, aggressive approach to therapy?
Yeah, so it's pretty good to start out with a conservative treatment. If there's no major neurological deficits, if we clear out those absolute or relative contraindications and make sure they're are safe and good fit for chiropractic care, to go ahead and see how well they can respond to it.
Yeah, I always try to tell patients that it's not about how severe the pain is, it's about how it will respond.
Right.
And if we have at one end numbness or tingling or pain, say in the foot or in the leg, that's not necessarily where the problem is.
Right.
And if we remove the problem from where the compression is or from where the insult to the nerve is, the pain at the other end will go away.
Right. So, in a lot of cases that I've seen, it's a spine problem and it's not an extremity problem. So, just because you have numbness, tingling in a portion of your hand doesn't necessarily mean that it's a hand problem. So, that nerve root extends or originates all the way from the base of the neck, right?
Yeah. So it's important to differentiate between a localized pain that's a neuropathic pain like a carpal tunnel syndrome
Right.
versus a radicular pain or a radiating pain that's coming from either the elbow or from the shoulder or from the neck, or in the case of the lower extremity from the low back. What are some of the things you do to make sure that we're treating in the right area?
Right. So, doing a proper exam is, and making sure that we understand where that nerve root or space occupying lesion is coming from. Right. So that's imperative in order to see if they're a good fit for chiropractic.
Yeah. What do we do that is significantly different than what, say, other forms of conservative intervention that would make somebody want to choose a chiropractic approach to treat radiating pain versus some other approach?
Well, we're really the only ones that are going to manipulate the spine and try to get some pressure off of that nerve root. Right.
Yeah. I don't know that we're the only ones. Have you run into physical therapists that manipulate?
Very few.
They are few and far between. They're getting better.
Okay.
I know a few, and the thing is, we do it all the time.
Right.
It's what we trained in, and we're really good at it.
Right.
Um, but that doesn't necessarily mean that
We're the only
we
ones.
don't have the corner on the market. Manipulation is or adjustments, if you will, I think are effective for certain things, but not effective for other things. And we were having a very interesting conversation about that
Mhm.
as to to what extent is our skill set as chiropractors effective and where is it not effective? What do you see in your practice?
So for cases that are not effective, um, well, let's take for instance, in a wellness practice, just your stiff and achy mechanical low back pain, we treat that very, very well.
Yeah, that's
But
going
if
to respond.
there's more of an underlying structural issue, disc pathology such as a bulge, protrusion, or herniation, it requires some more other interventions.
Yeah. So does that mean that if you had somebody that has one of those pathologies, do you automatically escalate to something more drastic? Or we were having this conversation about uh, within our profession, the specialists
Mhm.
and what specialties there are. I don't think very many people know that there are chiropractic specialties.
Yeah, and I think that we should look at chiropractic through the lens of specialty and understand what chiropractors do and have access to in their office as far as modalities or treatment protocols.
Yeah.
Which I mean, looking at I mean, back in motion, disc and joint, this is peripheral neuropathy and disc rehab.
Yeah.
That's your bread and butter. That's what you specialize in.
Yeah, and in fairness to other offices as well, there are chiropractors that treat sports injuries. They specifically focus on performance. There are chiropractors that do prenatal or care during pregnancy. There are pediatric chiropractors.
Yeah.
There are chiropractic. What other specialties? Chiropractic neurology, orthopedic.
Functional neurology is a big one.
Yep.
Um,
So
Sports rehab, I think you already mentioned that, but that's
the
another big one.
So there are within the chiropractor profession, it's not just, well, I've been to a chiropractor, so every chiropractor is going to be the same
Yeah,
type of approach. And I think that that's something I wish we could get that out to the public a little bit more fully. That when people are looking for a chiropractor, they should look for the right chiropractor.
right.
So if I'm looking for a medical doctor and I've got a nerve problem, who do I look for? Look
Neurologist.
for a neurologist, right? I'm not looking to go to the kidney doctor if I've got a nerve problem. And I wish that we kind of had that same uh, level or scope of specialty where uh, we could each say, oh, yeah, I'm a disc specialist, or I specialize in extremity work, or I specialize in sports rehab, or and have that recognized. So if somebody's looking for that, they know that this doctor does
Mhm.
this and this one does this.
Yeah, and I mean, I think that's something that we should embrace is the collaboration between colleagues and different healthcare professionals. I like to have, because I have my limitations in a wellness type practice, right? I'm not going to be this silver bullet for every person that walks through. So I like to have other professionals that I can send out to because at the end of the day, my interest is in the interest of the patient and
Y-
getting them better.
And I think that if we can all land on that page, that we should make decisions clinically in the best interest of the patient, that would serve us well.
Yeah.
Um, so what's the difference between, say, a wellness clinic and a specialty clinic in terms of what patients should expect? What, like, in a wellness clinic, how do you direct patient care?
Um, we direct patient care firstly through, it's a very minimal type of exam. And we're not doing anything comprehensive. We're just kind of, checking some range of motion, maybe do a few ortho and neuro tests, rule out some red flags, and then kind of figure out what's going on. And we just essentially have three stages of care: relief, recovery, and wellness. So the grail of like what we're trying to accomplish is people coming in without any pain or symptoms and seeking the health benefits of chiropractic. That's kind of the wellness model, is to get health benefits of chiropractic and not necessarily treatment of a condition.
So when you're so the wording is very interesting there because I use similar wording when I'm talking to my patients in relief, correction, and rehabilitation.
Yeah.
Um, but how do those differ in a wellness clinic? Because I do drastically different things with my patients when I'm in a corrective therapy mode versus relief mode. When we're just trying to lower inflammation, we're
Yeah.
trying to lower pain generators and get some relief from pain. That's a totally different care approach than when we're trying to correct, say, biomechanical or cellular dysfunction.
And the only thing that changes in a wellness practice is frequency in which you're getting adjustments.
Right. So we should, and you can argue with me if you think I'm wrong, but uh, the adjustment and how often you get adjusted isn't necessarily in and of itself a corrective therapy.
No.
It's not going to, just because you get adjusted more frequently doesn't mean you're going to get better faster,
Right.
right? So there are other things that we have to do in order to facilitate healing. So in a wellness practice, that you said relief, recovery,
Hmm.
and
It's pretty similar to corrective care, recovery care. It's most of your symptoms have been mitigated at that point, but it's still important to be consistent with care to keep getting results and keep improving
all right. So it's more holding steady while the body recovers and
and
heals
adapts. Yeah.
and adapts to
Hmm.
that. And I think the difference between that and what I do is we're facilitating an actual change in physiology during when we're dealing with discs or we're dealing with nerve healing. We've got to facilitate correct function rather than just allowing the body to do it.
Yeah.
And more complicated cases require more complicated care.
Of course.
So what do you think? So one of the challenges, I used to work in a wellness clinic. One of the
Hmm.
challenges, it was always somewhat frustrating to me, was that my patients didn't necessarily think they needed the same frequency or consistency of care that I did.
Hmm.
Is that something you run into?
All the time. Yeah. Or really, it's just like the quick fix. Like I'm just I just want a quick fix. And one adjustment in and of itself, regardless of where you are in your healthcare journey, is transient relief. Right. One adjustment's really not gonna do much other than get you some pain relief for a day or two. And it's really not intended to do anything more than that. That's not treating of a condition. That's pretty much nothing. It's maybe a step in the right direction, but
So yeah, we talk about the philosophy of care, I
mhm.
suppose. Like it's your mindset in going into approach treating a patient. Uh, what in your mind is the chiropractic adjustment doing for the patient?
Restoring function, resetting the nervous system, improving range of motion and quality of life.
How do we show that to patients? Is that just something that anecdotally they feel, or is there
Well,
some?
it's good to have some functional tests that you do, um, whether it's a functional movement assessment or range of motion, just some simplistic stuff, or just monitor their activities of daily living. But those are kind of, pain is very subjective,
Yeah.
but it's certainly hard to measure those sorts of things.
And so I'm not sure. I'm always trying to nail this down because I mean, don't get me wrong. I'm kind of playing devil's advocate because I love adjusting my patients. I mean, you've spent the day here with me. I mean, I adjusted pretty much everybody, and
Yeah, of
so
course. That's what we do.
there's a lot of value to the adjustment. But I do, although especially today with all of the, I hate using the term misinformation, with all of the access to videos and AI and WebMD and all this, people think that they know what's happening with it. And I'm not sure that we do a good job explaining why we adjust, what the purpose of the adjustment is, what the benefit of the adjustment is,
Hmm.
and what other things we ought to be or the patient ought to be doing for their level of self care.
Yeah, well, it's important to tie it into their concern, what their chief complaint is, and ultimately what their goal is. So if their goal is just pain relief, I'd try to develop or structure a treatment plan to get them pain relief, you know? But, just because we mitigate symptoms doesn't necessarily that we mean that we've cured your condition.
Yeah, which is no different than a medical approach, say to neuropathy with gabapentin or Lyrica. Like it's not fixing anything; it's just covering symptoms. Pain management. You do. I had a conversation with a pain management doctor not that long ago.
Right.
Radio frequency ablation and epidural and steroid injections. They're non-therapeutic.
Yeah.
They just cover up pain.
Yeah. That's what they're meant to do.
So if we treat somebody only for pain relief, are we doing anything more or less than a pain management doctor?
No, we're not. So that brought up a big point of the topic that we were going to talk about today, which is I wanted to ask what your patient treatment philosophy is.
It's a good question, and it's changed over the years. I mean, I've been practicing a 20 something years here.
Learned some things along the way, huh?
A few, and some things work, some things don't. And I would like to think that I'm following clinical data. And I think it's important that we follow data and information when we're treating people so that we're not over treating, under treating, and we know how to approach things. But basically, when I'm structuring a treatment plan, my goal initially is to get the patient out of pain as quickly as possible.
Mhm.
I don't do a whole lot with function at this point. My goal is to
Decrease inflammation.
decrease inflammation and oxidative stress, so we can basically plug the hole in the dam
Correct.
or the boat.
Right.
I feel like a lot of times when people are chasing pain, either through pain management or they're taking NSAIDs or they're taking this supplement or that supplement or trying this stretch or that stretch, it's like the person standing in front of the dam that springs leak. They put their finger in it, and another one springs leak. Their finger in that one, and they're just chasing this, but the stress is still there behind the dam.
Right.
Eventually, you don't have enough fingers to plug the leaks, and it's going to break loose. And that's where we end up with catastrophic failure and got to have surgery and that type of thing. Whereas if we can, instead of putting our finger in the hole, we can patch it.
Mm-hmm.
We can lower the stress behind the dam.
Right.
And we do this on a cellular level. And I think it's important to understand that adjusting doesn't remove pain. Adjusting stimulates certain physiological responses in the tissues, in the muscle tissue, in the connective tissue, in the nerve tissue. And it's certainly part of getting relief.
Yeah.
But understanding the chemical component and what's happening inside the cell with reactive oxygen species and oxidative stress on the tissue and how that responds. What therapies can we use beyond adjusting to lower pain generators? Okay. And it's important to know what those are. Interleukin 1, 6, 10, tumor necrosing factor alpha. These are all things that we could measure, and based off of the treatment, we can see those things drop. And there are certain therapies we can do in order to do that. Adjusting is only a small part of that. So obviously I'm not in a wellness clinic. I'm treating people that are in some type of crisis, either cellularly or histologically. They're having pain for all intents and purposes. Then once I get through a pain, I've lowered their pain threshold and the intensity of the pain, hopefully 80, 90%. And I can work in the tissues without reigniting a lot of the inflammation. It's like hitting your thumb with a hammer. I hit my thumb with a hammer and it swells up and it's hot and it's swollen and it's throbbing and it hurts and the thumbnail's falling off. And if I protect it and I let it heal, it'll be fine eventually. But if every 3 days I smack it with the hammer again, it's going to reignite.
Yeah.
And it's just going to hurt for a really long time. It's never going to get better. So if we move from a relief care treatment, relief focused treatment to lower inflammation and lower oxidative stress, If we move from that into a corrective care too quickly, we can reignite a lot of those inflammatory processes, because in corrective care, you have to begin to stress the tissue. You have to begin to stress the body, stress the joint. The appropriate stress creates a positive response in the tissue that allows us to create endurance and longevity in the healing.
Mhm.
It's like the roots in the grass. If you water every day, or what is it? Yeah, you water every day, a lot of water, the roots don't grow very deep
Mhm.
and the grass is very fragile.
Yeah.
But if you water a few times a week for a longer period of time, the roots will go down, the grass becomes stronger. So the stress, the heat stress in between on the grass creates a much stronger system. Same thing in your body. If we don't treat as frequently, if we if we're doing the types of adjustments or the types of therapies that create stress on the tissues in an appropriate way, we will get much stronger and longer lasting healing.
Yes.
Okay. So the balance is between activating certain cellular pathways. Early on, we've got to lower inflammation and have cell cleanup. So we want to activate what's called AMPK.
Mhm.
That pathway is a signal for cells to clean up. Well, there's damage. Okay, certain cells have to die off, and they got to be replaced with new cells. Uh, Other things are just used metabolic waste that's just got to be cleaned out.
Mhm.
Okay, once we get all of that stuff cleaned out, then we activate mTOR, which is a pathway that signals protein synthesis and cell rebuilding. So we've got to create a stronger foundational structure for that healing to happen. If
Mhm.
we build on fragile tissue, it's just like the lawn that has shallow roots. It's just going to get heat scorched. The smallest stress on it is going to create problems. It's not going to be strong.
So, how do you know when to graduate into your corrective care with patients?
I think some of that is part of the reason why I think experience and specialty is really important, because certain tissues are going to respond faster. For example, a muscle.
Mhm.
Say I have a muscle strain. Muscle's really highly metabolically active.
Very vasculature.
A lot of blood supply, a lot of oxygen, hopefully. Um, and if you can optimize healing, we have a time frame. We know typically what 6 weeks, 6 to 8 weeks. We should be able to get a fairly well recovered tissue, right?
Mhm.
Unless, of course, I'm playing on LSU's football team and I still got to do ladder sprints or whatever. Uh, the stress on that, if I stress it too quick, it's going to not be as strong.
Right.
Right. So we have a time frame. So typically we take I'll take a window of kind of average. First, so for a muscle strain, I would take the first 2.5 to 3 weeks and want to start with maybe some intermittent fasting and some glutathione and some of these things that are going to help with cellular cleanup, antioxidants, things to lower inflammation, curcumin. And then the adjustments are going to be fairly gentle. They're
Mhm.
not going to be overly stressful. They're going to be mobilization, maybe some flexion distraction type adjustments, maybe an instrument adjusting. If they're really, really healthy, I might do a manual adjustment, but I don't want to overstress the tissue while I get that lowered inflammation. Uh, After that 2.5 to 3 weeks, say in a muscle strain, I know that that tissue should be strong enough to take a little stress. How do I know? Well, we take them, like you mentioned before, we take them through range of motion. We take them through some stress tests, some muscle tests. I had a patient this in the last few weeks had knee patellar tendonitis. So a really good test is to start doing body weight squats or
Mhm.
walking lunges to put stress on the tissue to see how much. If I stress it a little bit and I get an inflammatory response or I get a pain response out of that, okay, well, I probably don't want to get into doing, inverted squats or excuse me, in incline squats. Thank you.
Incline
My
squats.
my brain had a short circuit there for a second. We don't want to overstress the tissue while it's still recovering. But if I start doing those tests, No, that feels fine. That feels fine. And I can get to, say, 10 squats and 10 lunges before I get a pain response. Okay, good. Now I know where the limit is. We're going to stress that tissue for 7 or 8 reps,
Yeah.
rest, 7 or 8 reps, rest, 7 or 8 reps, rest. We're going to start stressing that, increasing the load on that tendon or that muscle till we get a pain response. And then once we get into the last phase, rehabilitative care, we know we've gotten through correction when we can go through all of those with no deficiencies, right? Then we can go into rehabilitative care where we get back into the activities that they were doing when the injury occurred, and we can begin to build endurance and strength. So we're increasing load rather than just increasing stress. We're increasing load.
Mhm.
Now we increase the capability of doing those things. So it is a bit of a dance because there's no hard and fast schedule for it. It healing is a function of time. Quality of healing, I think, is a function of care plan.
Yeah.
Because what percentage of patients, if they did nothing for their non-specific low back pain, what percentage of patients would get relief from the pain with doing nothing?
With doing nothing, maybe half.
No. So so we should only treat half?
No.
No. The difference, I think, is if we have a structured care plan with specific health goals in mind, I need to be able to do X, Y, and Z. Then we set a time frame for being able to do that.
Mhm.
Okay, so if I blew a disc out, it's not a realistic goal that in 6 weeks I'm going to deadlift 400 pounds.
No.
That's not going to happen.
No.
But what I can do is based off of a timeline say, okay, in 6 weeks you can be 80 to 90% out of pain,
Mhm.
and we can begin to stress tissue without generating inflammation. Start strengthening that tissue. And 4 weeks after that, we ought to be able to start loading, and we can have a smoother progression. And at the end, we have a stronger tissue because we followed this pattern of graded loading, of de- decreasing frequency of care, allowing stress to accumulate on the tissue without allowing that stress to go to break the dam,
Right.
in essence. So that's kind of my care philosophy, and it's obviously condition dependent. But I think it's where a lot of people go wrong in terms of patient care is uh, starting exercise too soon,
Mhm.
or yeah, I strained a muscle. I just needed to stretch it out. No, the problem is it's already overstretched, dude.
Yeah, that's the worst thing you can do
Like,
is stretch it.
don't overstretch an already overstretched muscle. Um, but knowing what to do, when to do it, and how much to do it
Mhm.
equals at the end a better quality outcome,
Right.
which is
Yeah.
why people are better off seeking care, even though 50% of those people with nonspecific low back pain may achieve pain free at some point. Absence of pain is not absence of problem.
Right. So the your first phase of your care, you're just trying to mitigate symptoms as much as possible, but that doesn't necessarily equate to clinical success. Like it's important to go through these phases of care and that pain in and or symptoms in and of themselves have their limitations, right? Just because we're absent of pain doesn't necessarily mean that this injury is healed all the way, that you're not susceptible to having the injury again, and that you're ready to go back into whatever activities you were previously doing before the injury.
Yeah, and I don't remember. Do you remember from? I think they told us this in school. What percentage of fibers within the nerve are actually dedicated to pain perception? It was like less than 10% or
Yeah.
something. You know, the A alpha fibers. I think they are. Is it the A alpha fibers? Now I'm showing my ignorance. I have to go back and review. If you don't use it, you lose it, folks. But the small nociceptive fibers, there's less of those than proprioceptive fibers, pressure fibers, vibration fibers, motor fibers. All of those things have to be firing on all cylinders. And if you if you compress a nerve, say with like a herniated disc, take for example, so you compress the nerve, you don't just compress pain fibers. you're compressing motor fibers, you're compressing sensory
Sensory,
fibers,
yeah.
you're compressing everything. And if that nerve swells, now you're choking off blood supply, you're getting hypoxic nerve, and the nerve begins to deteriorate, and you end up with a long-term neuropathy. So pain is an indicator that there's a problem, but the absence of pain, there's fewer pain fibers in that nerve. So the majority of that nerve is being affected without even setting off pain signals.
Signals, right.
So this is why, I'm sure you've seen patients that come in, they don't really have pain, but they got foot drop,
Mhm.
or
Yeah.
they don't have pain, but they're walking kind of, their hips are doing this weird, you know,
Yeah, their biomechanics are
it,
just totally
yeah.
off.
And so I asked a patient this not too long ago. He was walking kind of, I don't hurt. I'm fine. I'm like, you see yourself walking, right? Like you feel is that normal?
It's very dysfunctional.
How did it get that way? Did you always walk this way?
No?
So what changed to create this dysfunction?
It's a accumulation of, postural stress and, all these things that build up over weeks and months and years. This didn't A lot of that stuff, it doesn't happen overnight.
And then they end up with this complex of dysfunctions that they don't, even though they don't have pain, is not really recognized as, say, maybe a neurological problem or a musculoskeletal problem. I don't have pain, therefore I don't have a problem. But you're, watching somebody walk through the grocery store, swinging their legs out to the side and around, and
Mm.
limping, and
I try not to pay attention. It'll drive me crazy. If you're going out in public and looking at people's gait analysis,
oh, it's
yeah,
terrible.
I
It's
can't do
terrible.
it.
No, I hear you. I do that all the time. People watch, and my wife will, she doesn't stamp on my foot, but she'll give me a little nudge. Stop it. Stop it. You're
So,
stirring. You're stirring.
I know what you're doing.
Yeah, that's right. Yeah, she'll do that. Uh, so, what types of care, um, should we direct? Let's say, how do I want to word this? So we have similar structures, but different desired outcomes within our two different models here, with wellness versus, uh, I don't know, what do you even call it, corrective, or I don't know, more complex conditions.
Comprehensive
Comprehensive.
chiropractic.
There you go. Comprehensive chiropractic. That's a good way to put it. So these different models, where do we draw the line on limitations on what we should do? Because I mean, you've been visiting with me today. I had a walk-in patient, and
Mhm.
like, this is not it was not. This is what a guy just wanted an adjustment. This is not the place for him,
Right.
right?
Yeah,
I'm not set up just to do crunch, crunch,
well,
crunch. Have a nice day.
it's a good point that you bring up there, in that you're not selling a service. You're selling a plan. In you're going through an examination process to figure out what's going on with this patient, and then developing an actionable framework in order to treat their condition. You're not just saying, "Oh, well, if you buy 10 chiropractic adjustments, you'll get 2 visits for free." Your disc herniation will love that.
Yeah, yeah. Well, that
You're
sounds
not.
effective, right?
Yeah.
Yeah, the models. There's uh, this is where I I'm still trying to dial in where and how I can work with within within our profession, and honestly with collaborative care as well, is recognizing the limitations of what we're set up to do.
Yeah.
You know, I I am not set up to be a wellness office, and I don't think it could I have adjusted that patient today?
Sure.
Yeah, I could have said, yeah, sure, come on in and we'll get you squared away. But does it do him any benefit for me to do that? I don't know that it's detrimental, but is there a place better for him to
Yeah.
go?
Yeah, absolutely.
If that's what he's after, a clinic like yours is probably more suited to what he needs.
Walk-in clinic.
A walk-in clinic that's set up to answer questions, but provide a basic level of wellness. I just want to I just want to get popped. I want to feel better for, whatever. No significant health problems, no significant issues, which works great for that.
Mhm.
Uh, on the same page as that, if I have somebody that comes in that's a performance athlete, am I the best place? And at what point do I say, I'm going to refer? Now, I have a couple different models that I've very clear delineations. I do not want personal injury cases. Do not want car accidents. I don't like treating them. And so I send them down the road.
Yeah.
There's a clinic down the road. They do a lot of it.
Right.
And they're good at it. So send them down the road. It's much better for them to be there than for me to do something that I don't enjoy and I'm not set up to do. Another one is, well, we talked about wellness, sports, um, uh, allergies and nutrition, functional medicine stuff.
Right.
I do some nutrition. I do nutritional support for neuropathy, but I don't do functional medicine. But there are doctors out there that are doing functional medicine. I don't do surgery. That one's a clear delineation. Instability and declining neurological function, got to go to a neurosurgeon.
Yeah.
All right. Endocrinology. I don't do endocrinology. I don't do rheumatology. If I've got I just had a patient not that long ago. Yep. Boom. They have certain metabolic autoimmune inflammatory processes going on. Can I adjust those people?
Sure.
Can I treat them? If they have musculoskeletal pain, yeah, I think it's probably appropriate. But am I going to manage that autoimmune condition?
No.
Is it appropriate for me to do so? I think recognizing the limitations of our own models is an important step for us to get the best care for our patients.
Yeah, and you totally got to throw the ego out of the door, and understand what your scope of practice is, what your business model is, what type of patients and conditions that you're wanting to treat, because we don't want to just bring in people just for the fun of it or just for monetary reasons, um, when they may have a certain expectation that you're the one that's going to help them. So to ascertain and manage those expectations is huge.
Do you think that patients would be more responsive to referrals between chiropractors if we did it more often?
Yeah, I get good feedback from it. So I don't do personal injury in my type of practice. So I'm in network with people that do. And then on the other side, if they have a patient that is more in alignment with what I'm doing, more of a wellness space, who's to say they're not going to send my way?
Yeah.
So it's a mutualistic benefit.
Yeah, between doctors for sure. My goal always is to change perception, or I guess perception is the wrong word, to increase the value of what people receive from what we do.
Hmm.
And I really feel like being honest with patients and being able to manage, uh, not drop the football, basically. If you get the football and you're a lineman with the football, very seldom do you run for the touchdown, right?
Right.
The rule number one for the lineman that picks up the football is what?
And maybe hand it all to somebody else.
Don't drop the ball, get to the ground. Just cover, protect the ball. But sometimes I think we try to do what we shouldn't be doing with what is not ineffective, but what is less effective. Does that make sense?
Yeah.
You agree with me, or am I just?
No, I totally agree with that statement.
I think that if we would more plug in with colleagues, first of all, patients would appreciate it more if we work together as chiropractors, but also if we work together with medical colleagues and in that vein, other conservative care approaches as well. That the patient would appreciate it more, but I think that also our education level with those other practitioners would be elevated,
Yeah.
and they would be more receptive to what we do. And I talk to a lot of medical doctors and a lot of aesthetics and a lot of pain management and a lot of rheumatology because I need I need those resources for my patients. And the more I talk to them, the more receptive that those practitioners are to hearing what it is that we do. Uh,
And that you're not just bringing people back and not doing an exam, not evaluating them, and just popping them.
yeah, and I think that there's a I mentioned this earlier today. There is a gross misconception within the medical profession of what it is that we do. And I think there's a couple of reasons for that. Number one, they're just not taught. They're focused on the medical allopathic approach to patient care, and they're not looking at they're not learning about a holistic uh, type of approach or a conservative approach.
Mhm.
Um, and I think the only uh, I'll hold that, but uh, they just don't have time to learn it,
Right.
basically, right? So
And
they
if they do know anything about it, they've done the research of their own on their own, or they've maybe consulted with a chiropractor before.
yeah. Yeah, and I think that I there's a responsibility on us to bridge that gap and provide that education in a responsible way, knowing that what we're sharing, it should be evidence-based, it should be reproducible, it should be predictable. And that's not to mean that we have to succeed with every patient, because not every treatment works with every patient, even in a pharmaceutical sense. So, but we can point to a lot of good data, clinical data, and studies that show the effectiveness of what we do from a conservative standpoint.
Mhm.
And I think it's just misunderstood what it is we do. And I don't think that uh, social media does us any favors.
Zero favors. If anything, is a detriment because all only thing I really see on social media these days in our chiropractic space is just, just absolutely barbaric cracking videos.
Yeah. Half of them, I wonder if they're, well, not even more than half, probably, whether they're even chiropractors doing
Yeah, a
it.
lot of them are like foreign countries and
Yeah, they have. Yeah, yeah. It's very cringy. But then my feed gets, because I'm always doing research on the latest surgical interventions, the latest pain management interventions. Of course, with the opioid crisis and the decrease in the ability of doctors to write copious amounts of opioids, we have the ability to step into that space and help with pain management for people with a conservative approach. But it's not. I got lost my train of thought somewhere in the middle of there, but we have an opportunity to bridge that gap in terms of helping people manage pain. So I remember where I was going. So I'm doing a lot of research on spinal cord stimulators and ablations and new techniques in pain blocks and those types of things. And then always want to keep up on new surgical interventions, prosthetics, particularly with the spine. Prosthetics historically have not been great.
right.
They haven't done well. Fusions are sometimes necessary, but awful. And depending on the neurosurgeon you talk to, they think they're great. I personally don't think that fixating a joint is a particularly good thing if it can be avoided, because you end up with adaptive stress on adjacent segments and then fits failure. You end up with having to
And
have
then you
4 or
have
5
to
surgeries.
fuse the segment above and or below.
Yeah, it ends up in a cascade of problems. But my feed, because I'm doing research on those things, my feed is loaded with surgeries and people explaining, okay, I'm about to do this surgery, and this patient, we're having to go in and we have to repair this because a chiropractor did this, and I'm just like,
It fits the narrative.
I guess it fits
It
the
it's
narrative.
it's the journalistic flair that the chiropractor hurt somebody and now they gotta go to a medical doctor. That's what
Okay, so here's my hot take. Here's my hot take. This may get me in hot water. Come at me, keyboard warriors, okay? Because I just don't care. But I find it just maddening, absolutely frustrating. And I don't even subscribe to this, but I hear this argument all the time. So if you look at the rise in autism and the number of vaccines given, they're right. So
Yeah.
that correlation is absolutely true.
Mhm.
I didn't say vaccines cause
Causal.
autism. Okay, that's not what I'm saying. I'm saying that the correlation is 100% true.
Yes.
Okay. Yet you see these guys saying the chiropractor caused a stroke.
Mhm.
No, he didn't. Patient was already having a stroke, and that is proven. That bears out in every study. I looked it up on PubMed not that long ago. I'm like, studies showing chiropractic cervical manipulation causes stroke.
No, there's not a
It
single
does not,
study that will say that it's causal to
it's
strokes.
not. In fact, at a proportional rate, the same number of people that had a stroke following chiropractic adjustment
And a medical doctor.
at a medical visit, it's the same percentage of people.
So, do people say going to a medical doctor is causal to having a stroke?
That's my point. Like they're saying they went and got an adjustment and it caused this person to have a stroke. It's the same argument as saying the vaccine caused the autism. There is a correlation, but you have to look at the data deeper. The reality is that those people had early symptoms of a stroke already in progress.
Correlation doesn't equal causation.
Yeah, absolutely. And if you want to hold to the argument that vaccines don't cause autism, you have to also hold to the argument that chiropractic adjustments don't cause stroke.
Yeah.
And they don't. There's ample studies out there that say that they absolutely don't. And I've now stopped. Okay. I used to get into it. Like
Yeah.
I would get on there and and then they'd come back at me. And everybody following that medical doctor is, guess what? Anti-chiropractic.
Oh, of
Right.
course.
So now you got 500 people, half of them are probably bots coming at you. You're a quack. Blah, 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 blah. All these Karens coming out of the text wilderness to come at me. So I mean, I don't even respond to them anymore, but I, I also, I haven't commented on them in a long time, but it, it's maddening that that idea still exists. And I've now chalked it up to a failure on our part as chiropractors to bridge that gap and
Mhm.
say, this is what we actually do.
About a month ago, I had a medical doctor come in the office, and he really only uses chiropractic acutely. But he requested for me not to adjust his neck, and I was like, okay, just for educational purposes, why? And he said that he's like, I've witnessed it. I've seen it happen. I've seen people leave the chiropractic office, and yeah,
Because he was in the chiropractic office when it happened.
mm, exactly my point.
No, I get people being nervous about it. That's a reasonable response.
But where does the apprehension come from?
Well, honestly, it's a fragile structure.
Right.
I
There are
mean,
very important structures in your neck.
seriously, you go into jujitsu and you pay to get choked out. Tap early, tap often. But really, how long does it take to disrupt the structures in the neck? Literally seconds,
Hmm.
right? So this is why I get really irritated and a little bent out of shape with all of that YouTube ASMR cracking stuff on there, because a lot of the technique that you see people, first of all, half of them aren't even real. The noises that you're hearing on there are fake. They're just doing it for clicks, but it encourages people to go try it themselves.
That too. And also, when we earlier, we were looking through some reels of some cringe adjusting videos, and I pointed out the fact that, and you pointed out the fact that they weren't doing an actual chiropractic technique. they were just making up their own thing, which is pretty dangerous.
Yeah, pretty dangerous. Let me see if I can find this.
But the point in me saying that is that to the layperson, they can't may not be able to differentiate a chiropractic technique versus somebody just wailing away at somebody's neck to make it crack.
Yeah, for sure. I agree with that statement 100%. Let me see if I can find this and we can uh, show people what we're talking about.
Which further perpetuates this apprehension and people being scared, and it's just more of an issue for us.
Let's do this one just for an example. Hold on. Let me move this back here. Yeah. Okay, here we go.
Adjustment for frozen shoulder or adhesive capsulitis. Let's take a look.
Okay, so this is supposed to be for a frozen shoulder.
A little bit of autonomic nervous system activation.
Okay, what do you see on that? What do you see on that adjustment? Okay, wait a minute. First of all, let's
It's a lot to unpack right there.
There is so much here. Okay, look at this dude. What the heck is this hairnet? And why is he wearing gloves?
Makes him look more like a medical professional, maybe.
I guess. I don't know. Maybe I have a fungal infection. I don't know. But do you wear gloves when you adjust?
Never, not once, not even during COVID.
No. So this guy already is suspect to me. All right, here you go. So
cervical spondylitis.
What?
Oh, wow. So not in chiropractic, you want to be very as specific to an area of restriction as possible.
Yeah.
And what we're seeing with that one is no specificity.
No. So he's contacting with the palm of his hand on the what I'm assuming are the transverse processes of the cervical spine. Other hand is up on the skull, extension, rotation.
That's almost like that guy's trying to induce a vertebral artery dissection.
Yeah, big time rotation, massive rotation. That's crazy.
But to a layperson, they may look like that's very similar to what a chiropractor is going to do.
Yeah.
In a chiropractic office, and that to us, it's night and day, right? It's so different, but
and then
done. Relocation of the humeral head on the glenoid. Good. Scapulothoracic joint.
Just asinine.
Have you adjusted the scapulothoracic joint?
Is that what he said?
Yes. Let's back it up here. Back it up here. There we go.
Scapulothoracic joint.
Wow.
Scapulothoracic joint.
It looks like he's just going to break some ribs right there.
After treatment, let's take a look at the same raising. There you go. Chiropractic adjustment for frozen shoulder or adhesive capsulitis. Let's take
adhesive capsulitis. Let's see, he cut out the first range of motion. But anyway, the point being, I think in all of that is that there is so much garbage out there that creates this idea that we do something that we don't, or that we're not doing things that we should. There is no context is important too, because I think that there are doctors on YouTube that truly do good analysis and they do good care plans, but they're only showing a short part of what it is they're doing. I think those are out there. But when was the last time? I mean, you going to show a surgery? You going to film that?
No. I mean, there are videos out there. Go look at it.
For educational, or are they on YouTube?
Yeah.
I guess maybe I had to look a little bit deeper, but I just think that that's weird. Like, why? Like I've never
Here
videoed myself treating
Here's
a patient.
another thing, though, that I blame chiropractors for, or people who do these types of videos. So it's now become so normalized to video an adjustment now that I will find people, like I'm in an open bay setting, I will find people pulling out their phones and recording me without my permission.
See, that's why I don't have open adjusting. Yeah, and you shut that down.
Absolutely, you have to.
I mean, that's
To
a
have
HIPAA violation.
HIPAA violation. I don't know where they're gonna send that or post that or anything like, and they're not even asking.
Well, it's not even your I mean, they need your permission,
Right.
but they need the patient's permission
They need the patient's permission.
because it's not you're not in public. It's not. I mean, there is an expectation of privacy when you come to the doctor's office.
Yeah. Uh-huh.
So
So I don't necessarily blame them or condemn them as much as I do other chiropractors for normalizing
yeah,
that, oh, during an adjustment, this is a time to like record and get a big reaction out of them and see if we can hear the cracks on the video and stuff. And I'm like, "Ugh."
yeah,
Please don't do that.
yeah, yeah. I almost think that the treatment is the easy part.
It's the easiest part about being a chiropractor is adjusting patients.
What do you think the hardest part is?
Whoo, education, bar none.
Educating the patient.
Y- eh, Yeah, or yeah, educating patients or just making people understand what chiropractic is.
I'm not that public forward, I guess. I'm more interested. Well, I mean, I do want to educate my patients, but I think the hardest part for me is putting the puzzle together. Uh,
You're so good at that,
but
though.
it's also the part that I enjoy.
Yeah,
You know, I enjoy that. I enjoy because very seldom do we get patients that come in and have one problem, right? I just have this. It happens, but it's usually in younger, more healthy people, right? But for example, somebody comes for me to comes here to investigate the treatment of peripheral neuropathy, and it comes out they have diabetes,
they have arthritis.
they have arthritis, okay, hypertension, just tied to diabetes, but and then a history of lumbar disc herniation, and they have respiratory issues and
They got an extremity complaint.
brain fog, and okay, so I mean that's an extreme case. So they might have 5 or 6 overlapping conditions that are all tied together. And see, this is where the difference, I think, between allopathic care and what we do, which is more holistic approach, where there's a little bit of a divergence. Because if I have all this, so let's take 3 separate conditions: peripheral neuropathy, diabetes, herniated disc, say sciatica.
Mm-hmm.
Okay. Is there one medical doctor that's going to manage that?
No.
Who's going to manage the diabetes?
Wait.
Diabetes,
Diabetes,
peripheral neuropathy, herniated disc. Is it realistic to see that patient?
Is it for one medical doctor to manage all 3 of those?
No, I was like, does that patient exist?
Yes.
Yeah, more often than you think.
Yeah, absolutely.
So, who's managing this patient? Who's managing the diabetes?
The medical doctor.
Probably the endocrinologist.
Yeah, endocrinologist.
Who's managing the peripheral neuropathy?
Neurologist. Or hopefully you.
Or pain management, or hopefully me. Right. So we got one guy prescribing the insulin dosage,
Mm-hmm.
one guy prescribing the Lyrica dosage, and what about the herniated disc?
Orthopedic specialist.
Either orthopedic specialist or the neurosurgeon or somebody that does those things. Okay. So now we've got, are those 3 things tied together?
They're three separate conditions.
Yes.
However, they can be tied together.
Does the diabetes affect the neuropathy?
Yes.
100%. Absolutely does. Glycation end products and reactive oxygen species,
Oxidative stress.
nerves start to die in the periphery. Yes. So the diabetes causes peripheral neuropathy. Does the diabetes also contribute to the herniated disc?
I wouldn't say no.
100% it does. Absolutely, because you have impaired metabolic function at a cellular level. You have impaired tissue repair. So diabetic sores heal slower
Yeah.
than non-diabetic sores. Is there a difference between a sore in the skin and a weakened annulus in a disc?
Just the tissue type and the vascular supply to it.
Exactly.
That's
So
it.
we get decreased metabolic function, decrease the same type of fibroblasts have to work in both injuries, right? If I tear the annulus, I still have to have fibroblast activity in order to repair that.
Mhm.
Same thing if I have a wound, I still have to have fibroblast activity in order to lay down collagen matrix and all of that. I still have to mobilize white blood cells and all of those types of things. So to say that the herniated disc is not tied to the diabetes that's a very allopathic approach where I'm compartmentalized. You have a herniated disc. Oh, and you also have diabetes. Oh, and you also have peripheral neuropathy. When in reality, we ought to be managing that whole person.
Mhm.
We ought to be, look, yes, the herniated disc needs to be fixed. We can do that conservatively. If that fails, you can do it surgically, but ultimately that tissue is impaired. If I don't plug the hole in the boat, it's going to sink.
Right.
The hole in the boat is your blood sugar is out of control. Your metabolism, your insulin resistance, you're creating a firestorm of oxidative stress in your body because you're not metabolizing sugars properly. Right? And so how do we manage that? Well, dietary supplements, insulin if necessary. I'm a big proponent of berberine. Berberine works fantastic to help that. Of course, if you're insulin dependent, you got to get your insulin dosage right. But with these peptides these days, the advent of peptide therapy has changed the way we look at conditions like diabetes. Type 2 diabetes is curable.
Reversible, even.
Reversible. I would never have said that 10, 15 years ago. That would have been a sure way to get called in front of the board. But we're seeing with GLP-1s, we are seeing a rapid amount of instances. That wasn't even a correct sentence. We're seeing massive amounts of people show up having utilized these GLP-1s that now are no longer insulin resistant.
Yeah. And what does a GLP-1 do? Well, ultimately makes them stop eating as much.
Yeah, so we're controlling the influx of blood sugars. Still has to be managed, and there's some drawbacks to GLP-1s, which I'm very interested in compounding pharmacies being able to do this. I'm not a big fan of pharmaceutical companies being able to patent and corner the market on these things. GLP-1s are naturally occurring in your body.
Yeah.
All we're doing is we're magnifying the effect of the GLP-1 by artificially increasing it. And what that does from the standpoint of it takes the stress off of the body and it can heal,
Mm-hmm.
right? So we're talking always about treat the person. Well, what are the drawbacks of the GLP-1? Well, we don't want people overutilizing GLP-1s because there's muscle mass loss. Well, there are formulations of GLP-1s that can be done in a compound pharmacy that add IGF. So you add growth factor, and all of a sudden you mitigate muscle loss.
Yeah.
Plus, patient education. You got to do the weight-bearing exercises. You've got to do resistance training to maintain muscle mass. That's really important.
You got to eat your protein, you got
but
proper nutrition still.
but why would we restrict the ability of doctors to be able to use a substance naturally occurring in the body to help cure something like diabetes?
That's a great question.
For those of you, whoever's watching this, if you don't know, peptides, there's BP. I always stumble over this.
BPC 157.
BPC 157. I can't get the C out. BPC 157. There's a bunch of these that have shown tremendous benefits to wellness, longevity, that are trying to be patented by Eli Lilly and other pharmaceutical companies, so that they can bill you, they can charge you an exorbitant amount of money for things that your body should naturally produce anyway.
Mm-hmm.
That's like getting a patent on vitamin D.
Yeah. Essentially.
It's ridiculous. It's ridiculous. The whole insulin debate is ridiculous. Insulin was discovered, not created.
Mm-hmm.
Insulin is, guess what? Peptide.
An endogenous hormone.
It's an endogenous hormone. So I think it's going to be a really, really awesome thing to watch, the development of peptides in regenerative medicine. And if we're not careful, I really think chiropractic is positioned in a really good spot to be able to kind of own that space, because we deal with naturally healing processes in the body.
Mm-hmm.
If we're doing our job right, we're providing building blocks and stimulus in order for the body to heal naturally, versus going in, cutting something out. Well, that's got to be excised,
mm-hmm.
Or let's burn that off.
Or just mass symptoms.
Yeah, or just mask symptoms. So I think it fits well within our paradigm, but if we don't do our research, and we don't stay up on the research, and we don't plug in to the advent and the development and the research going on with that, we're going to find ourselves left kind of in the dark ages. By the way, happy birthday, Chiropractic.
Happy birthday, Chiropractic. 130 years old.
Woo! 30 years old today, which is what? September 18th.
Yeah.
September
1895.
Modern chiropractic. Bone setting's been around for a lot longer than that.
The first chiropractic adjustment ever was performed today, 130 years ago, and restored hearing in Mr. Harvey Lillard.
What do you think about that story?
I think there's some truth to it. I think a lot of it's maybe lost in translation too. So I don't know. I wasn't there.
You ever had something like that happen in practice?
Not something that dramatic. No. Mm-mm.
No. I do see all the time people that get adjusted. They're constipated, and then all of a sudden they get adjusted and they have to poop.
Yeah. Yeah.
Or they were
You stimulate those parasympathetics.
IBS,
Absolutely.
and then all of a sudden it normalizes.
Yeah.
I've had patients that were struggling getting pregnant that then were able to get pregnant.
I've seen a couple of those.
Yeah.
And we can't make the audacious health claim that chiropractic can get you pregnant.
Not legally, unless the chiropractor's doing naughty things.
Right.
They shouldn't be. No, that's sorry. No, I'll edit that one out. No. No, there are circumstances that they're really cool stories, and I don't know, maybe Harvey Lillard really did get his hearing restored. That'd be pretty cool. I would like to be able. So see, this is where, even if that is true,
Mm-hmm.
can I explain to my patient how that happened?
I could not. I couldn't do it. How did we stimulate a cranial nerve lesion through cervical manipulation? I can't explain it.
There are many things that in not just chiropractic, medicine, that are totally inexplicable.
Yeah.
Like I don't know how or why that happened, but it did.
Yeah, you always hear the story. Yeah, the doctor told me I wouldn't be able to walk. I wouldn't be able to do this, this, and this, and they defied the odds. It always makes a great movie
Yeah.
every year or so. So
So when I get something that's inexplicable like that, I typically don't ascribe it to the wonders of chiropractic. I typically, man, the human body's amazing.
yeah,
You
what a
know,
blessing. That's fortunate that happened.
yeah, I can't take credit for it. If I can't directly, like if I'm doing dry needling and I have a myofascial trigger point that's just on fire, and I put a needle in it and I stimulate it and I pull the needle out and I can go, oh yeah, see, it's gone. Like that's easy to explain.
Hmm.
Like I'm stimulating that trigger point, I'm manipulating the myofascial tissue, and when I pull it out, it relaxes and we reset the muscle tension, and that's easy to go from point A to point B. If I can't do that, I don't typically like to see how wonderful I am. See how wonderful chiropractic is. No, I more ascribe that to just the miraculous and incredible nature of the human body and
Design.
physiology. It's unbelievable.
The human design is, I mean, it's fascinating. It's a lot of what probably drove both of us to be in this profession.
Yeah, I would say so. Although, looking back, I got to say that as a teenager, I was probably more fascinated with the cracks and pops.
Well, you outgrow that really fast.
You do outgrow it. And then you spend the rest of your life educating people that, hey, the pop is not everything.
Yeah.
It's not everything. Um, what else is going on in practice for you?
Oh, um, usually, I get a lot of something that we kind of touched on earlier. I think I just forgot to mention. It's maybe 3 or 4 patients a week that I'm getting. They're coming in as new patients, and they're saying that I'm scared, I'm terrified, and really a lot of it, it's their first time there. They don't know what to expect, but also they're seeing the cringe adjusting videos. Their neck is in a lot of pain, and they're scared of someone else touching it.
Yeah.
So it really comes down to education, making the patient feel safe, making them understand that you know what the heck is going on.
Yeah. Somebody's got, I'm driving the boat. You'll be fine.
Yeah.
Yeah.
I see these cases all day, every day. You're in good hands, you're in the right place, giving them that affirmation, um, under making them understand that, the the movie you saw where the ninja cracked somebody's neck, I'm not trained to do that, right? I'm trained to get you better. Right. So that usually clears up a lot of the apprehension when we're able to talk, just face to face and clear up any apprehension that way.
Yeah.
But
So earlier last week, I made a video and post. I want to get your thoughts on it.
sure.
Did you happen to see it? It was
Maybe.
about the Charlie Kirk
Yeah.
assassination.
Okay.
Did you
Yeah.
see that post I
Yeah, I
made?
did. I watched the whole thing.
What do you think before I ask you?
Um, it was. I mean, uh, it was a good video. I mean, it wasn't anything like provocative, or it wasn't like you know, I mean, it was just like, guys, like we need to wake up, and we need to get together, and we need to all come together and
So I the it brought thoughts to my mind because look, I'm not I don't know, maybe I'm not the type of person that's going to go, okay, I'm going on a crusade now, I'm going to call up Fox News and want to put in my 2 cents, or I don't really want a political podcast. I don't really want to talk about all that, but
yeah, that's not our space.
what I do want is to be able to have conversations that create unity and that create understanding rather than division. Or I really try not, I really, really try hard not to criticize other doctors. I'll do it in general. And I don't like this idea, but I'm not going to say, Dr. Jack over there's
A retard.
he's doing this thing and it's super dangerous, or it's super bad, or this surgeon over here is really terrible. And, it just doesn't serve any purpose. And I really think that 99.9, there's always the 0.1% maybe, of physicians don't have bad intentions.
They're
right?
doing what they're trained to do.
They're doing what they're trained to do within the scope and within the understanding of what they do on a daily basis and what they see. And how can I take the lessons of hatred drove some crazy individual to take a rifle and kill that person because they didn't like what they said or how they said it? Now, I don't think that there's rampaging chiropractor out there with a rifle or a rampaging medical doctor out there trying to assassinate the chiropractors of the world because they dare to say that chiropractic is great.
Well, there's a lot of condemning comments. There's a lot of pejorative things that are said online. Yeah, we've definitely been under the gun.
Yeah, yeah. I mean, we've been the whipping at the whipping post for many decades within the medical realm.
Yeah,
for sure. But I've been trying to think to myself, how can I elevate the conversation within my own sphere? Any thoughts on that?
Really just coming down to whoever you're talking to, whatever their level of understanding is, and just always having some sort of empathy and compassion to where they're coming from.
Yeah, I wish there was something more broad, other than this type of format.
Yeah.
I just, and I'll continue to invite. By the way, in that post, I invited any medical doctor that had a different opinion than me to email me. Guess how many emails I've got? I don't know whether it's an ego thing, whether they're not interested in having a discourse or a conversation. It's, I mean, I guess all I can do is what I can do, I suppose. But
Control the controllables, man.
yeah, but other than this format, I wish there was something more we could do in order to get that. Because again, ultimately, creating a discourse of harmony and good communication and getting our egos out of the way is super important, I think, for our
'Cause
patients.
we're serving a higher purpose, and that is patient care.
Yeah.
Our clinical interest needs to be in the best interest of what the patient needs to get them better.
All right, folks, we would love to see you. As always, you can reach out. By the way, you can reach out to Dr. Jennings at The Joint on Segan Lane. If you have a condition a little more complex that you would like to have looked at, herniated disc or peripheral neuropathy or some such condition, you can reach us. You can look at our website. It's backinmotionbr.com. You can reach us here at the office at 225-501-8050. And we will look forward to seeing you in the office. Have a good one, folks.
Bye-bye.